Well, good afternoon. Welcome back to the home stretch. We're almost there, right? I feel like I got my back to you guys over here. Turn over. Hey guys, how y'all doing? So we got a panel discussion that we're going to have. It's going to be a fun one. Did you guys go through the vendor hall and see all the antiques and all the old Respiratory Museum? It's pretty cool. So you got myself, Zach Gantt, CEO of Encore, and then Gene Gantt, who's the CEO of Aventa. And we actually are in the same office. So we're in Livingston, Tennessee. If you've never been there, it's like a Hallmark movie. And so come during Christmas. We have Christmas in the country and horse and buggies, fire pits, all the fun stuff, just like the movie. Anyway, but on the square in Livingston, it's really cool because you got all these boutiques and shops, and then you come around and there's a couple iron lungs in the window and all these respiratory antiques. And so people walk by. My office is right inside the window, and people walk by all the time and see the iron lungs, and so they're always coming in. And if he's there, he'll tell them the story. If I'm there, I'm usually on a webinar, and so I'm sitting there talking on the phone, and people are coming in trying to learn about the iron lungs. And then recently, we had a development recently. If you guys saw that baby iron lung, we had the 2 iron lungs, and we left them in there at night by themselves, and they made a baby. And now we have a baby iron lung, and so that's how that happened. But anyway, so we're going to have a fun talk. We're going to go through a lot of the history of respiratory care, the evolution of respiratory care, starting at the beginning, and then where we're at now, and then where we're going. So he probably will do more of the talking on the history because, I was in diapers in some of the times we were talking about. So he'll do some of that talking, and then we'll talk about where we're going in the future. So welcome back. 2 sessions left, and we'll be done. Has it been a good conference for you guys? Yeah? It's been fun. It's been really good. And so happy that you guys came and continue to come. It's awesome to see everybody and have a time we can get together. And we don't do this enough in the profession. There's so much value in doing it in person. So if you're online, I challenge you to come here next year because it's so much better in person. And you can win the door prizes.
And you can't see the leaves from online.
Yeah, you can't see the leaves online. All right, well, let's go.
All right. So there's our objectives. Now, what he did mention is he gave me the slides last to put the last few in there, so I loaded it up pretty heavy, so I got most of the time.
Yeah, so, it's all right.
I told him he could talk some, but, mainly just to ask questions. So
there we are.
There we are.
In 1982,
we had a message from the president for you.
In 1982, it was my pleasure to sign a document proclaiming the first National Respiratory Therapy Week. Today, 5 years later, it's with equal pleasure that I congratulate the American Association for Respiratory Care on the occasion of its 40th anniversary. Over 22 million Americans are afflicted with chronic lung disease. Over 70,000 deaths occur annually as a result of pulmonary disorders, and several thousand people suffer some degree of permanent disability. The economic expense of these diseases has been estimated to cost $16 billion annually. As you respiratory care professionals surely know, the cause for some of these diseases is unknown. For many, there is no cure. But with your help and the timely initiation of appropriate therapy, the suffering of many patients can be relieved. Therapy slows the progress of disease, reduces permanent lung damage and respiratory disability, and delays and averts life-threatening complications. Although the lung damage already caused by these diseases cannot be undone, respiratory therapists may help preserve lung function that might otherwise be irretrievably lost. Your role in our healthcare system spans all age groups. Whether it's caring for critically ill youngsters like Katie Beckett or on most precious older citizens, respiratory care practitioners are there to comfort and rehabilitate and alleviate their problems. On this, your 40th anniversary, all of America salutes you. 30 years is not such a long time, but when we look at the impact of technology over those years, the effects of the healthcare industry are astounding. The profession of respiratory care, being based in technology and the use of life support equipment, has changed markedly in those years. From the amazing capabilities of the first iron lungs to today's use of computerized ventilators, technology and people continue to perform miracles. And you, the people in respiratory care, are leaders in learning new technology. Believe me, I have come to appreciate the role you play in our healthcare system firsthand. When I was in the hospital in March of 1981, respiratory therapists administered oxygen and monitored the ventilators used in my treatment. You truly are a vital link in our healthcare system. And the AARC is your vital link to the respiratory care profession. Your association is playing an important role in patient care through the advancement of respiratory care education, standards development, and health promotion. As members of this organization, you are affirming your commitment to the millions of patients who benefit from your work. Nancy and I send our heartfelt thanks and best wishes to you on your 30th anniversary. Thank you, and God bless you.
Not every day we get a message from the president, right? So I think
he's been going around telling everybody that the president sent us a message. He didn't say which president.
Yeah. It was no lie.
It wasn't a lie.
Really
Wasn't a lie. But one person said, "I hope they use a teleprompter." I don't know.
Well, we won't get into that. Well, you see how important that was. That was big. The day that we got the president to talk about us was huge. And if you noticed, he said the technology changes in the last 30 years. At that point in time, we were only about 30 years old. And that was in '82 when this was done. He was shot in '81 and did have firsthand experience. And that was I hate he got shot, but it was kind of lucky for us that it happened, you know. But we were involved with him, and I thought that was pretty cool that we had that message. And I just remembered having that and was glad we could play it so y'all could see. Nowadays, we say Happy Respiratory Care Week, and you get a pizza or whatever, but it was a big event. How many of y'all remember when Respiratory Care Week came to pass? So a good many of you then. Okay. Very good. Do what? John Walton, yeah. And there was a picture made with John and all the folks too. So, and then he talked about Katie Beckett as well. The Katie Beckett program was a huge thing. And it's funny, some states are just now enacting Katie Beckett, even though Ronald Reagan signed it into law. And unfortunately, our state was a little slow, but we did enact Katie Beckett just a couple of years ago. And we were very fortunate to be involved in the design and the implementation of the Katie Beckett program here. So the timeline of respiratory therapy, of course, I can't see it. I wrote it, but I can't see it. But it began back in about '47, and you can see the different changes that were pretty key. The name changes. We were first the Inhalation Therapy Association, and then we've changed names to the AAIT in 1955. And our first annual meeting was that same year in Chicago, and it was a relatively small group of therapists at the time. And most of them were from New York, Chicago, the more major markets, and that's where respiratory therapy, of course, was born. In the '60s was when the first registry exams happened, and then in the '70s you started seeing some real growth in leaps and bounds. Things started catching on and technology started changing, and then by the '70s, we exploded out into the rural hospitals, and that's when the growth really happened. And those were the cowboy days that we'll talk about. I wanted to bring this picture up because I don't know, in my mind, this guy over here on the right was a respiratory therapist, but if you notice, he is holding a knife of some kind. I don't know if he just did a trach or what, but I was curious about his technique, but he does have a knife in his hand. We have an iron lung that came off of a movie set. I don't know if this was the same movie or not, but we bought it in Chicago for $200 on eBay, and it cost $2,000 to ship it to Livingston. Then we had to have a rollback truck to unload it off of the big truck, and then we uncrated it and brought it in. It's still functional, so if you come to Livingston on one of those Hallmark days, we'll recreate this pretty little scene. I won't do a trach on you, but it does cost $5 to get in and ride it and $500 to get out. So there's a little bit of a premium.
It's negotiable. I mean, once you get in there, we'll see what happens.
And we do have, it's funny that we do have a lot of tourists that stop at that window and they're just astounded because who expects to see an iron lung in Livingston, Tennessee? And a lot of people stop and say, that's a nice tanning bed, and then we explain to them that don't work either. But
it'd be kind of awkward to get naked in that window and get in there. I don't know.
So not long ago, let's tell you a funny story real quick. Not long ago, there was a group working. We had 2 air conditioners that were zapped by lightning at one time, so we had a big work crew came in. I don't know if you were down there that day, but they were eating lunch at your table or at your conference room table. And they started asking about it, so I thought, I'll show it to them. Well, there's a mannequin inside of it, and the head sticks out, and of course, the body's inside. And as I rolled that thing back, this guy saw that body, and I thought he was going to pass out. He thought, oh my God, he started backing up. Well, I guess he thought it was just a head in there. But the polio epidemic was a big stimulus for our profession. Now, I did not work during the polio epidemic. I do want to clear that. I am older, but not that older. But the polio epidemic got so bad, as you can see, a giant polio ward here. And I cannot imagine what that was like. And you have to think about the fact that we had no blood gases at the time. It was all hit and miss. We put people in there and did best guesses on how much ventilation they needed. So I thought that was a pretty interesting picture.
Never thought about it, but it'd be really hard to do a blood gas inside of an iron lung.
It's almost impossible.
Yeah, I'd say so.
But I would hate to be the guys over there in the beds waiting on the iron lung coming next. You can see there's some that are not in the iron lung. But that was the progression. Then we ran out of iron lungs, and I think this picture is pretty phenomenal to see. But this is an entire chamber that was pressurized so that we could ventilate 4 children at one time. Again, imagine that these 4 children were all breathing at the same tidal volume, same whatever. Of course, their body build is going to differ, but each one of them, was having to adjust to whatever pressures we're pulling down to. And so you can see there's a doll right up here on the outside of this child's face, and that child could see that doll, but they couldn't touch it. But if you look at the other picture, there's an identical doll hanging inside. So they could reach up and get it, and they could touch it. So they would have to pretend that they were playing with their doll. The other nurse reading to them. And I always ask students and others about this nurse that's in there. Would she be breathing at the same time as these children were? And of course the answer is no, because the children's heads are outside at ambient pressure. What would happen with that nurse is she would be deaf from the fact that we just put a negative 60 centimeters of water pressure in there and sucked her eardrums out. The baby iron lung, if y'all had a chance to see it, was in there. This is the only one I've ever seen. The other one is, the only other place I've seen it is the AERC Virtual Museum. This was a really good piece that we got a hold of. We actually bought this from a museum, a medical museum in Kansas City. And we bought the entire contents of the museum that was respiratory products. They had Indian artifacts there that were Indian medicine, and they had a surgical piece, and then different rooms they had. But we bought the respiratory room, and we had an adult iron lung and this iron lung, and we sent I don't know, what was that, 26 or 30 foot box truck to get it, and it came back with just a little bit of stuff in it. But anyway, it wasn't easy to get to us. We didn't want to pay $2,000 shipping, so we sent $2,000 worth of truck instead. As I said, we have visitors come. I don't know if y'all know Tammy. Tammy's from Charleston, and she happened to be in the area on vacation, and heard that we had an iron lung and stopped by the office, and she got in the iron lung and she experienced it, and it's pretty tremendous to get inside. It's a different feeling if you've never been in one. So you can talk every once in a while.
I will in a minute. Yeah, we get a lot of people in there. You'd be surprised. We probably operated more iron lungs than most people that are existing in the profession.
Yeah.
Mostly in our office, but yeah, Tammy came back and brought her entire family, and so we had like a whole tour going on. There's 20 of them or something, and came back, and a bunch. They all wanted to get in, so we gave them all a ride. We made a lot of money that day, didn't we?
We did.
Yeah.
We racked up. I have been in the business a long time. I was lucky enough to start working in respiratory therapy when I was 16 years old. I was first an orderly for about 3 weeks, and then one day the doc that owned the hospital, who had polio when he was younger, had gone through medical school in a wheelchair, that kind of thing. But one of my jobs was to get him in and out of his car every day when it was time for him to go home. And one day he started talking to me about his experience with polio and with the iron lung and things of that nature. And again, I was an orderly pushing him around. And somebody came by with a bird mark 7, and they just walked past me with that bird mark 7, and I said, "What is that?" And the doc told me what it was. It was a new ventilator, replaced the iron lung, that kind of thing. And I said, "You know, someday I'd like to do that." And sort of nonchalantly said that. And the next day I went to work, and my time card had been moved from my little slot where I was orderly over to inhalation therapy. And so it was that easy.
Yeah.
Ask and you receive. This is my dad. My dad was EMT, and one of the first EMTs back in the 70s when emergency medical services finally came to be. But prior to that, it was the funeral homes that were running ambulances, and of course that was no fun. So
Seems like a conflict of interest too.
it seems like they all had those governors on. They would go 30 miles an hour, you know. And it was funny then in those days because the funeral homes each had an ambulance service, and there were 2 funeral homes in town, and they would compete for the business. They of course wanted to come pick you up, you know, before the other one did. Both of the hospitals were owned by doctors in my little town that I grew up in. And they had been owned by their daddies and their daddies before that. So this was doing CPR. In my biology and human physiology class, I had all kind of fun because I would bring that, or I'd bring EKGs from the hospital, or different things like that, ambu bags, and play around with that. So by the time I got out of school and went to respiratory school, I already had 2 years of on-the-job training under my belt, which gave me a tremendous boost up.
And you lied about your age too, right?
Yeah.
That helped.
That helped, yeah. So and so that puts me at 50 years. Last month was my 50th year in respiratory therapy. Yeah. Yay.
And you're only 52, right?
I'm 53.
That's pretty impressive. Yeah.
We talk about, I see a lot on the message boards about the tests and people taking their tests, your registry exams and all that, and sometimes they complain about them and whine about them. But let me tell you something. We had oral exams. And when you walk in the room, and these are the 3 guys sitting across the table from you, which the 3 guys that did my oral exam, and they can ask you anything they want to clinically, and then you got another room with 3 other guys, and those 3 other guys ask you about equipment, and they can ask you whatever they want to. And there was no script, there was no study guide, there was nothing, no PowerPoints to study off of. So in those days, of course, these are the guys that wrote the books that I used, and I assume you're still using. And of course, it's not the first or second edition of them anymore, but more than that. Dr. Bone became the father of palliative care. He himself died of cancer, kidney cancer, and there are some. If you Google his name and go online, you can find there's some great interviews, including one on 60 Minutes, I think, where he talks about palliative care, that we know today, but he doesn't call it that, but he talks about the way we treat death, and death being a part of life, and that kind of thing. So that was a pretty big event. In the late 70s, the cowboy days I mentioned. So I won't read all that, but go ahead and flip through. There were so many companies out there that were contracting with small rural hospitals, and we would plug in entire respiratory therapy departments where there were none. So we would go to a town like Livingston, Tennessee, where we got a new contract. They'd have a hospital, no respiratory therapy. Usually we found that the maintenance guys were doing the oxygen setups. They were bringing the cylinders out into the rooms, things of that nature. Or if you had pipe gas, they were in charge of the oxygen bank. And there was maybe a Bird Mark 7, maybe 2, and then whoever was available would do the treatments. It didn't matter. There was no scientific basis to it whatsoever. So all of these companies started up, and we started seeing, as I said, an explosion out in the field of respiratory therapy departments. And I had the good fortune of working for one of them, and by virtue of the fact that we were going into these little departments, they had old and antiquated equipment and a lot of antiques, a lot of which you saw in that room in there, because I'd pick them up and put them in my pocket and take them with me. So we would bring them new stuff, and we would take the old stuff, and it became part of my collection. The problem with some of these companies was that and I'll say in a minute, IPPB was king, was they abused the system tremendously. And everybody was on IPPB. And everybody got a pulmonary function before surgery. And if it was a sore toe or whatever, you still got IPPB because it helped everything. And we joke about how albuterol cures everything now. Well, IPPB did then, but we used different medications at the time. You see the laryngoscope here. That's actually an anesthesia device. It was out there. And you would pull the end off of it, put chloroform in it or ether, and then line the holes up, and the patient would inhale it, and that would be the start of their anesthesia. The product on the end, Dr. Nathan Tucker's asthma-specific nebulizer, I didn't bring the product itself. I brought the brochure. The product itself is on loan to the DEA Museum in Washington, D.C., because, and I asked the guy like I was stupid one day. He called and said, "Can we put that on loan at the DEA Museum?" And I said, "Why the DEA Museum?" He said, "Well, that's how they took cocaine." I'm like, "Oh, okay." The Beckman analyzer, we had it out there as well. For those of you that stopped by while I was there, I would always push the button and show you that the light still shows, and it still reads 18% oxygen, even though it hadn't been pumped up in a long time because the bulb is gone. But it had a bulb that you would pump and pull up a sample. And Beckman was an engineer, not a physician. And this was developed for use in submarines. Because we were losing a lot of guys because we were running out of oxygen while they were underwater, and that's not a good thing. So the Navy first developed, it was developed for the Navy first and then for aerospace. And then one day somebody said, "Hey, we could put it in one of these isolettes where these babies are that we're pumping in 100% oxygen and see what the oxygen level is." And Beckman was responsible for the sudden decrease in infantile blindness as a result, because we were, making kids blind. But it worked off of a very interesting system with 2 glass bulbs and a magnet, and oxygen has magnetic properties, the only gas that has magnetic properties. So once you pumped it up, got your sample in there, the oxygen molecules would be pulled over to one side. It would tilt this thing, and a mirror would show you what the concentration was. So no batteries, no electricity. It was all chemical responses. And there's the isolate. And Beckman made this famous comment that, the greatest reward was that they helped preserve eyesight for thousands that might otherwise be blind. Pretty incredible what technology was coming up. It's an oral airway that's never been used. You can tell. can imagine the teeth marks on there. So, at one point in time, we had the DRGs came into play. And does everybody know what DRGs are, diagnosis-related groups? So prior to that, we were paid on a fee-for-service. Every time we did a treatment, we got some money for it. So again, these companies that proliferated that whole, let's give everybody an IPPB, were running rampant, and the cost of care was going out the roof. And it didn't look like there was any end in sight. So CMS came up with the DRGs, and all of a sudden, everybody thought all the hospitals are going to go out of business. And we thought, and we've heard this before, respiratory therapists are going to go away because we don't have a place anymore, because we don't have a payment for what we're doing. And I see that amongst people all the time, or comments again all the time on the message boards about how until we get paid for our services, we're never going to be functional in a hospital. We do get paid for our services. It's just not a direct payment for that IPPB or whatever we did. It's here's the money, and y'all do whatever you do to make the patient better. And if we do a good job and have good outcomes, then we have made money for that hospital. So that's about how it works. Bird Mark 7, y'all know about Bennett AP5, Puritan Bennett AP5. And by the way, that little anesthesia device I talked about with the chloroform, that was the very first Bennett product. Not Puritan Bennett, but Bennett product. And later it became Puritan Bennett. Drug-wise, we use this wonderful drug called isoprel. Anybody ever used isoprel? So, have you ever taken isoprel? It's like getting a shot of epinephrine, You would give that to a patient that couldn't breathe, and by God, they could breathe after that. They couldn't sit in the bed, but they could breathe. So it was a very good drug. But luckily, some other drugs came along. Different versions of IPPB units. This was a very early Ohio Chemical made this particular device, went directly onto the 50 PSI cylinder, which we had a lot of in the hospitals. They would be chained to the walls, hopefully chained to the walls, or on a stand of sorts. I had one of these, a large cylinder one time that about killed me, not because it fell on me, but it had a cap on top. If y'all recall, they had a cap on top. And this one had been outside in the oxygen bank for a long time. And I went out one day to get one to take in the hospital. And I rolled that cap off, as we used to do, a real fancy thing. We'd roll it real fast to see it spin, And there was 1,000,000 wasps in that sucker. And they came out, and they were mad at me for some reason. And in their confusion, they stung me all over my face and neck, and I had to go into the ER and get me a shot of isoprel.
Is that the needle they used right there?
Yeah, that's the needle they used. So the needles, the blood gas syringes, of course, there's a glass syringe, and some of y'all will remember that. For y'all that are younger, it's hard to imagine that we would use that glass syringe, and then that night we would wash it in some soapy water, and then we would put it in a ethylene oxide sterilizer, which we used to sterilize it, and then the next day we used it again. I mean, that was the way it worked. Later we found out that ethylene oxide causes cancer, so we stopped doing that too. Luckily, we learned a lot along the way. One of these ambu bags, if you've ever used one of the original ambu bags, it has the best feel to it. It feels like you're touching the lungs and squeezing them. It's a great, great feeling. If anybody has one of these stuck away, I'll be making a big offer for it if you've got one to put in the museum. I do not have one. A couple of years ago, I had the fortune of going to Portugal for a few days, and as soon as I landed, the driver that picked me up said, "You have 4 consults at the hospital." And I said, "What? My profession doesn't even exist here." And they said, "No, the doc wants you to come see these patients." So I got to the ICU at the hospital in Lisbon, and every patient had one of these over their bed. They're still using these today. And I tried my best to get that in my pocket, but it wouldn't fit.
Next year, you can bring all your antiques, and we'll have an auction during this section. You can sell them all to him, and
Now we're talking.
There you go.
Yeah, that's a good idea. So, with the DRGs, I've kind of already explained that. It's a package deal. They figured out you get so much money for pneumonia, you get so much money for this diagnosis, that diagnosis, and whatever you do in those categories is what you do. I already said all that. And there's more stuff. So when we bring in new employees, I always roll the MA1 into the conference room and tell them we're ready to do our competency exams, and they'll look at me like, what is that? And nobody's ever seen it. But our MA1 still works too. The spirometer still works, everything still works on it. But how many of y'all used the MA1? Most everybody yeah. And that was big time when we got MA1. We were in tall cotton then, no doubt. The R2D2 Monahan 225, very good ventilator. It was great for MRI because it was MRI compatible. It's all pneumatic. And the only downfall with that machine was that the bellows would continue to work even if it was not hooked up to a patient. So in my experience, I have seen in hospitals, one hospital in particular that did not have a respiratory therapy department from one of these contract companies. They called me one night and said, we have a 20-year-old woman that had a baby, and we gave her general anesthesia. That was the first flag. General anesthesia for a normal delivery, and then they put her on a ventilator, and they couldn't get her off the ventilator. And I went there in the middle of the night and saw her, and she had been dead probably for about 24 hours before I got there. I said to them, your cardiac monitor is not working. And they said, no, I said, she's dead. And they said, no, it's just not working. There was a straight line on the cardiac monitor. They said, it quit working a couple of days ago. I'm like, Jesus. But that was what fooled them, was it didn't have a exhalation spirometer. It had just that bellows in the middle. And they swore up and down the machine was working, and it was not. Those are the kind of things that happened before we came along. And so when you think about how important we are, I mean, we've saved a lot of lives. That lady should have never died. So as I said, the 90s were turbulent times. There was a lot of reorganization. You can talk anytime. I'm sorry I loaded it up.
We're about to get to me.
Oh, are we? Okay.
Yeah.
All right, good.
I was there in those days.
Yeah, you're about there, right. So there were a lot of things that happened management-wise during the 90s because everybody was still reeling over DRG changes and things like that. But, a lot of departments went under nursing. That happened. I saw departments go under physical therapy departments. That happened. I always wondered why they didn't go under us. That was always my thing, was why didn't they go under us? And home care started happening. And home care in the early 90s was pretty easy because you could put a piece of equipment out. We'd sit around the table on Sunday and fill out the paperwork, and it was just one page that you did. And you send it in, and with the codes, and Medicare sent you a check the next week. Bing, bang, boom, it was all done. And we saw then that a lot of companies that were just really unusual got into the home care business. Avon Cosmetics started buying. Y'all remember when that happened, some of you? Yeah, exactly. Green and Kellogg. They were accounting companies that started buying DME companies. They were cosmetic companies that started buying DME companies. Everybody wanted to be a DME at the time. And equipment was becoming more prevalent. Oxygen concentrators, I think we've got a picture there. Big as a house, just about. We found that a lot of patients liked those big ones a lot because if they didn't work, if they quit working, they'd just use them for a kitchen table and pull it in there and just eat off of it. But that was the early days of home care. And unfortunately, there was never a lot of emphasis put on the clinical side of it. It was all about the equipment.
Yeah. That's about the time you started, right? What year did you start in home care?
In home care, our company, we started in 1982.
82. Okay.
Yeah, so 82 was and so we were buying these from another DME company. We were buying used buns or DeVilbiss concentrators that were, I think they're 150, 200 pounds. And then we buy them used, and then we would put them out, and as long as they were putting out oxygen, that we would check with that Beckman analyzer I showed you a while ago that was made in 1950, then we continue to use them. When we didn't need them anymore, we would export them, and they sent them to Mexico and to Central America. And that's where I learned about using them for a kitchen table. I mean, they literally would.
Yeah, and then when they started in home care, if you come to the office and see the museum, you'll see the brilliant business plan that they put together. It was on a bar napkin, and they had the math on there. If they did enough concentrators in the year, they could make $2,500 to split between him and his brother to have extra beer money. And so with that $2,500, $1,250 apiece, he convinced his brother to move from North Carolina to Livingston, Tennessee, to make that extra $2,500 a year for beer. He really liked beer, didn't he?
He did like beer.
Apparently.
And actually, we made enough to pay his salary of $12,500 a year, and then the $2,500 was our bonus. So it was big money in those days.
Here we go.
Yeah, you go.
Now it's my turn, huh?
Yeah.
So where are we at now? I think we're in an interesting time because as we talked about the evolution of healthcare, where we used to get paid for services, then it became DRG, and now we're really in this place where it's about value-based care. And we've always added value to the healthcare system, but it's always been a question of how do we get paid for that value? And so our struggle has been that there's no direct payment for our services, especially outside the hospital. There's never been really direct payment, or there has, but then it'd go away and then it would change and evolve. And so when there's not a direct payment, it means that there's no quick path to go get paid for our services. And that's been the challenge that we've had, right? But I think now we're in this interesting time where so much is wrapped around the value proposition of how can I improve overall outcomes or reduce readmissions or improve quality, and all those things drive payments for hospitals, for doctors' offices. I don't know if you guys know this, but there's a large percentage, 75, 80% of the payments that are coming to docs these days are based on value-based care. And so I've heard docs that say that if they work with certain insurance companies, they make 10 times what they would make for Medicare. But the reason they make 10 times as much is because they are controlling quality, improving outcomes, keeping people out of the hospital. And so they have all these incentives that if you do a better job caring for a patient, reduce the cost of care for this patient population, then you can make a lot more money as a physician because you're saving the healthcare system money. And so Humana and Cigna Health Springs, all these companies have had incentive programs for years where docs can make more if they save money on COPD populations or if they save money on certain populations. And so the challenge that I think we have as a profession is that we're not very good at following the money. And what I mean by that is that if we don't know how things get reimbursed, oftentimes when you work in a staff position, you never really think about how does a hospital get paid for my service. You just know your director says you better do this, this, and this, and so you do it. But you don't really understand the money side. But when you start to understand how the money flows, it really changes that dynamic, right? It's like when we train people to do business. When you teach them how to do things, then it really changes that dynamic of them wanting to do it because now they understand why we're doing it. And it's not just I told you to. But I think as a profession, we've struggled with understanding some of these basic things about how does the business side of healthcare work. And when you do understand that, it really helps to understand that there's more of an opportunity now than we've ever had. And what I mean by that is that now we're in this position where if you think about a doc's office who could get paid that much more, and I told you about an extreme case, but what if they just got paid 150% of what they normally get paid? If they could get paid more because they save money for a COPD population, how much value could we bring to that office? Right? But we're not thinking about that because we're thinking about, well, there's no direct reimbursement for what I could do in the office. There are a few things you could get reimbursed for, POTs and things like that. But the challenge that we have is we're not thinking about the big picture. Right? We're thinking about what can we get paid for tomorrow instead of if I partnered with these physicians or I partnered with a pulmonologist or I partnered with whoever, a skilled nursing facility or a hospital, how could you drive revenue and better outcomes to that organization? And so those opportunities are all over the place, but we're missing them. And so other people are capitalizing on those, and we've seen respiratory therapists starting to get into some of those environments. We really need a business school out there. AARC needs to do something, or we need to do something where can teach some of these things, because there's so many opportunities. I mean, there's a pathway now where respiratory therapists could make money for a primary care physician, a pulmonologist, inside of a SNF, inside of any environment, in home care. So there's a way to do that. The problem is we're not teaching therapists how to do that. So if you don't figure it out on your own, then it's really hard to get outside of the walls of the hospital. And so we've got to do a better job as a profession of recognizing that we've got the best opportunity that we've ever had to be able to capitalize on our profession and be able to drive our profession outside the walls of the hospital, and that the roadmap's really already been made. We just got to figure out how to pioneer some of these things.
That'd be a good session for next year.
It would.
I think we just answered that, but
We did.
I'll add to what you say and fall back to something we talked about yesterday when Dr. Hess was up here. The other panel is we in the past did a really poor job of data collection. And part of the reason we did a really poor job is because we didn't have a lot of data collection tools. And because we didn't collect data on the front end about the difference we made with COPD patients when we were putting oxygen out, like I was talking about, the fact that we didn't do all that and didn't track our clinical outcomes, it was detrimental to us because nobody could really prove what they said. Nowadays, we have, with all the things that we now have the option of collecting that data. And that's why it's very important for you as a home care company or as a hospital or in a skilled nursing facility or wherever your work lies, is to keep good data and have a good resource to collect that data and some way to validate it. And now that we're doing that, we're able to go in and say, look at here what we saved you, and that's what makes us more valuable. That's kind of what spearheaded my entire company right now, is the fact that we were able to say, here's what we did, here's how much money we saved, and here's the validation of it. That was a big thing.
And I think we were making a lot of progress before COVID in kind of advancing some of these things in the profession. I think COVID put the brakes on a lot of things and created a lot of chaos in the marketplace. And before, it was like you got to meet these certain standards to work here. I remember seeing a funny video where it was, you can't have tattoos and you can't have this. And then the guy came in, he had like a FU tattoo on his forehead, and they're like, you're hired, So we got in a place where the industry was desperate, right? And so really changed what respiratory looked like, because the standards decreased to a big degree, and we saw that, right? I mean, there are places where you could only hire these certain standards. Well, now it's like anybody that's got a license, even if you may not have a license, you can still come work here. And so things changed over the last couple of years, and so I think we lost some of that, but we're seeing it come back. And some of that is that we've got the advanced practice respiratory therapists. Anybody heard of that? You've been following that? A mid-level style respiratory therapist where eventually, hopefully, we can create the ability to write scripts and to be able to do as much as a nurse practitioner, work in a physician office, master level programs. And so there's a lot more master level respiratory programs out there. Used to, it was baccalaureate level, but now you're starting to see that master level programs are coming out. And so a lot of things are evolving in the profession. And nobody likes the conversation about BS degree being the entry level. Everybody's like, I don't want to do that, and I get it, right? I get it. But I think the challenge is that when you look at every other profession that's ever gotten paid for, they didn't get paid for until they got past the bachelor degree being the entry level. And so there's no possible way. CMS doesn't recognize less than a bachelor degree. Not that we wouldn't all get grandfathered in, the people that didn't have it, but I'm saying that in the past, CMS has never recognized less than a bachelor degree to pay directly for physical therapy, occupational therapy, any of those therapies. And so it's not an argument about are we good enough, with an associate degree. It's just an argument of if we want to advance and we want to get to a place where we can get some of these services paid for, we've got to raise the standard, right? And so that is the challenge is that I think we've approached it the wrong way of we just need to raise the standard. But if we explain this is why we got to do it, because if we don't, we can't get to a place that there's a payment for our services. It's not about, saying that you're not good enough if you're not at this level. It's about saying that we've got to do this to go to the next level. And we're starting to see some of that. I think those conversations are going to come back up.
Yeah, I think even the physical therapists have now moved to a doctorate level.
Yep.
I mean, they're really reaching out there, and that's not even that's somewhat unpopular in their profession, but in our profession, again, I remember a time when we were arguing about whether licensure was good or not. You remember, Colleen? We had states that said we're not going to be licensed because that's bad for the profession. And it's bad for the OJTs that are out there working because there were a lot of OJTs. And then we moved that bar and we started having an associate degree, was entry level. The OJT went away. Now we've got a ton of bachelor degree people out there already. And I see that continuing. And with the advanced practice, if you think about it, in 10, 20 years from now, I would love to see this happen, that there may be freestanding respiratory programs, an office where you could go in if you've got asthma, you could go in if you've got COPD, see your respiratory therapist, get your treatment. They can bill for that. They could help write some scripts for what you need specific to your disease. But I see that as coming, but it's not going to come until we reach that master's level or more. And it will come. The profession will move that way, and we can like it or not like it. It won't affect me. It won't affect a lot of us because we're going to be grandfathered in at whatever happens. But for the future for this profession, if we want to see it continue, then we should be advocating for those changes and supporting that. I think anyway.
And I think the other thing that we see in the last several years is that before, if you wanted to do something beyond being at the bedside, it was a lot of working for the manufacturers. A lot of respiratory therapists invented devices, those types of things. But you've seen the last couple of years, I think we've gotten pretty far in the devices that we've invented.
Absolutely.
And so how many more ventilator modes can you change or adjust, right? We're to a point we got a lot of modes and a lot of settings, and maybe something new and creative comes out, but we've done most everything when it comes to those types of things. But where you see the innovation is in software, artificial intelligence, all the things that are kind of coming about in technology. And so I think the next level of where we see the evolution and where we're starting to see therapists work in is in software, in the ability to do remote monitoring. And if you think about the ability to do remote monitoring, today at our fingertips, we have the ability to track so many things continuously in the home. And nobody's really doing it well. And so in the cardiac world, in the diabetes world, there's a lot of remote patient monitoring that's doing really well. In the respiratory world, we haven't seen a lot of that yet. There's some stuff out there. There's really cool devices out there where you can track respiratory rate, steps, those types of things. But you just imagine, if we had that type of data on a COPD patient in the home, where we knew how many steps they took in a day, we knew what their respiratory rate was at night while they were sleeping. Those little measures could tell us that they're going to have an exacerbation the next few days or the next week. And so all that the ability is out there to do all those things. And so there's opportunity for us as a profession to say, how can we capitalize on taking those things that are available and creating new ways to care for patients? There's billing codes for it. Physician offices can bill for RPM. And so if you think about, what if you went to a pulmonologist and put together a program like that with the technology that's out there, and we could track steps and respiratory rate, call those patients 15 times a month. It would change everything about how you manage that patient population. The technology's there, the billing codes are there, everything is already in place, just nobody's putting together the model. And so there's so many opportunities for us to go beyond what we've done in the past, think outside the box, and really get away from, not get away from the bedside, but have opportunities outside of the bedside.
Right, and from a ventilator perspective, technology perspective too, looking forward, there are ventilators right now that are available in Europe that are they can make, the home care company can make ventilator changes remotely from their phone without having to go to the patient's home. So if you've got a patient that's doing bad, you can adjust this or that without ever going there. That's going to be big for the DME industry here because we are shorthanded. We are, less therapists than are available, and we don't have enough, and it's not covered, even if we did have enough. But still, I think those advances are going to be pretty cool.
And I think that the challenge you have today is the FDA has not got on board with doing remote changes on ventilation devices. And so I understand why. It makes sense, right? But we are in a place where we've got a shortage of respiratory therapists. We're gonna need to evolve, and a lot of times people don't like the remote care model. But I think when you've got not enough respiratory therapists over the next 10, 15, 20 years, how are we going to manage the things we have to manage if we don't start to adopt technologies to do some of these things? And I know physicians that that manage patients in third world countries from their offices in California or wherever, and they can make ventilator adjustments. There's nobody else there to do it, right? And so the question is, if we don't do these things, it's not replacing the bedside care, but if we don't do it, then are we hurting the patient, right? Because when you think about telerespiratory, and we talked about that some yesterday, but telehealth plus respiratory therapy is the new term is telerespiratory, and you see these telerespiratory companies out there that are doing programs, and that's really came about since COVID, and we've seen a lot of that happening. I mean, there's a ton of this type of service happening, from managing CPAP and oxygen patients to ventilator patients to doing COPD programs. And so the opportunity for you to have respiratory therapists in front of a screen managing patients, I mean, you think about if you have to drive to every patient and they're 50 miles apart, you can see a couple patients a day, right? If you are doing it in front of a screen, we could manage hundreds of patients with a small team of respiratory therapists. And so it really opens up the horizon for us to do the things that could be done remotely, not to replace being in the home, because you still need to be in the home or still need to be in the facility or whatever it is. But if you could augment that and give it a little bit of pressure support, right, a little bit of boost, then we could start to see more care happening and better care happening for respiratory populations through these types of programs.
And you say 50 miles away, I can tell you that, and I know, Roxanne, you deal with this, some of the patients are 250 miles away, and you've got one in Colorado or Wyoming or Montana. I mean, how do you not care for those patients? You have to care for them somehow. And to put a therapist on the road to go 250 miles to make a ventilator change that needs to be done like right now, that puts the patient in danger. And so that exists all around. And we're lucky here because we don't have that. But in the other parts of the country, we do have those deserts where you've got these big extreme distances.
We actually have a customer in Alaska. They have to take a plane to get to some of their patients. And so could you imagine going to do a vent check and having to take a small plane to get there? It's crazy, right? And they don't get paid any more in Alaska than we do in Tennessee or they do in New York, where the patient's right next door and they're having to take planes to get there. And so the model is different depending on where you're at in the country. And we're in rural Tennessee a lot of times here, and so there are patients that are far out wherever you're at. And so the ability to adopt these things is going to change our profession and really create more opportunities for us. Again, like we talked about yesterday, nobody wants to give up breathing treatments because that's what's always been what drives a lot of our workload in the hospital. But are those things really bringing value? And we have to ask the same question in the SNF and in the home. Are the things that we're doing bringing value, or are they just what we've always done? And if it's what we've always done, then aren't there other things we could do better, like actually managing disease processes, keeping people out of the hospital, instead of just managing widgets and doing education, right?
Real quick, I'll mention we're running out of time, but we're looking at alternate care sites, skilled nursing facilities that have ventilator units, things like that. In the past, we've had great care in hospitals, and we got good care at home with home care companies that have done a good job. But if a patient ever went to a nursing home ventilator unit, it was just kind of like a drop them off in the garbage can kind of thing. They had very little respiratory oversight, very little monitoring, very poor equipment, things of that nature. So rolling out of the Respiratory Compromise Institute's inaugural meeting in 2017, I partnered up with the Patient Physician Alliance for Health and Safety, which is an international patient advocacy safety group. And together we formulated some criteria and some standards of care for these long-term care facilities. And we had once tried to go from state to state and get states to implement standards of care to improve that care. But we found out that that was like Groundhog Day, because Medicaid directors last about 12 months and then they're gone. And so you have to start over every time. And no matter how much the old one loved it, they never told the new guy about it because they just left and took their stuff with them. And we tried going to CMS one time, and we said to CMS in Baltimore, we said, you need to implement these standards for nursing home care. And they said, oh, that'll take act of Congress and 50 years, and we can't do that. But what would it take for you to take more patients into these nursing homes? And I responded with, well, double the rate you're paying. And they said, okay. And they did. And I'm like, seriously? You can't improve the standards, but you can double the rate just like that. So we've started this accreditation. It's been endorsed by the AARC. It's endorsed by the Respiratory Compromise Institute. In Tennessee, we have 2 facilities that are already accredited. All of the facilities, there's 6 total, but all of them will be accredited by mid next year, as it will become mandatory if you're going to get an enhanced payment rate, a higher payment rate. We've done 2 in Hawaii. I went there over the last month and did 2 down there in Hawaii.
Poor thing.
I know, it was hard. It was terrible. Slave drivers. Anyway, so we got that done. We've got 1 in Indiana that's done. I'm doing 3 in New York in late November. And we're doing 5 in Chicago before the end of the year. So we've got a really good, robust start. This just started in June, and all of a sudden we've got that many that are accredited and moving forward. So that's enough of that. Probably not. I mean, we've already talked about some of this stuff, the role of our people, all that. I always like to reflect on how far we've traveled from the iron lung now to, you saw these ventilators here, the Brios and the Voxen. I mean, they're teeny tiny. They do almost everything. It's just incredible that we came from here to there to there. In my time at work, that's except for the iron lung, those things. Go ahead.
I do want to mention, though, that, I think that I mentioned AI as the future. I know we only have a couple minutes, Colleen, so don't be giving me the look.
She'll start going like this.
Yeah, she should be giving me the...
It's when she stands up I get scared.
Yeah. So the one thing that I say is that AI is one of those things that's kind of scary for a lot of people, right? We think about the Terminator and what's going to happen when AI takes over the world. But AI has this place in healthcare that is really amazing when we start to work with it. And we're doing a lot with AI. And the ability for us to be able to take patient data, feed it into artificial intelligence, and then tell the future. And so we have a model that we've created where we can plug in information about a large population of patients, and we can tell you how much money you would save by having a respiratory therapist in the home over the next 5 years. And so, we plug in 5,000 patients, and it says $100 million you could save by putting respiratory therapists in the home. And so we're doing a lot of this with AI to try to predict not only exacerbations, what's going to happen next, but also take patient data and start to tell the story that if we had respiratory therapists in the home, this is what we could do. And so for the first time ever, we've got the ability to use data, and AI, machine learning, is really enabling that, as well as being able to predict the future, right? So if we have a large population of COPD patients, like right now we have 130,000 patients that we're feeding to an AI model and a machine learning model, which means that every time we change how we care for a patient, like if you update one of the protocols and it affects how well patients respond, then it learns that, and then it continues to evolve. So it's this continuously evolving wheel that says, oh, if you do this, then this will happen. So let's do this every time. And then you can continue to do that. Respiratory therapists are feeding the information in. Eventually, we'll know exactly how to care for a population of patients because of artificial intelligence and machine learning. And so the ability to take some of these newer, futuristic kind of models and build them into the data model today is going to change the practice of respiratory care. The things that used to take years to go and do studies on, AI will be able to pull out predictions and the data instantly, right? And so it's really going to change everything about how we practice.
My only regret, I don't have 50 more years to do it again. That's the only thing I regret. Next slide. The things you learn down here and here and here and here are what gets you up to the top. Don't ever stop learning. Keep on going. And these meetings are important, face-to-face meetings.
Especially this one.
Yeah, especially this one. And I think that's it, right, Colleen?
That's it.
One other thing. Yay, happy
Oh.
birthday, Zach.
Hey.
Happy birthday to you. Happy birthday to you. Happy birthday, dear Zach. Happy birthday to you. Ta-da.
Thank you, guys. Thank you.
And 50 more. Yeah.
Thank you, guys. This was
Thank
fun.
y'all.